Ready to start our second surgery broadcast live from the operating room. Our patient is having endoscopic Duke laser disc repair, L4-5, L5-S1 on the right side. She has pain in her back at the L4-5, L5-S1 region, and she has symptoms in her right leg. And we have just finished the first surgery. Our patient from the first surgery is about ready to go home, and we're getting ready to do our second case. Okay, so we're going to broadcast the entire surgery live for you to watch. Can you hear me? It's Dr. Duke. You okay? Are you comfortable? All right, we're going to get started here. Now, you're going to be awake in just the beginning, then we're going to put you to sleep, okay? But I need your help for the first couple of minutes. Now you might feel a little stick and some burning. That's just numbing medicine going in, okay? Don't get upset. Don't try to get off the operating table. If you feel pain, just say ouch. And if it's in your back, say ouch, my back. If it goes down your leg for some reason, say ouch, my leg. All right? Now, do you have mostly lower back pain or mostly right leg pain? Mostly lower back pain. And what kind of problems do you have with your right leg? You have to sit after walking for 15 minutes. Why? Hurts all the way down your leg. I got it. All right. So you got a pinched nerve. We're going to unpinch it today, okay? All right. Remember what I said. If you feel any discomfort, say ouch. And I'll give you some more numbing medicine, but try not to move around. Don't do that, okay? All right, you'll be okay if you do it, but just don't do it too much. Otherwise, I'll have to put some disco music on. All right, I'm going to give you some numbing medicine. That's just my hand feeling around. Okay, you'll feel a little pinch and then a stick and a burn, and that's just the numbing medicine going in. Everything's okay. Any questions for me? All right, so folks, for watching this surgery is done under sedation, but just not yet. We don't like to sedate our patients unless they need sedation. And anytime you sedate somebody, you run the risk of them being over-sedated and not breathing or vomiting and not protecting their airway and having an aspiration pneumonia. So we want to make sure we sedate when we need to, and only when we need to. So we kind of fine-tune the surgery to where our patients are sleepy when they need to be. The rest of the time, I need her awake helping me, especially for the beginning. All right, you comfortable? We're going to get started, okay? Let me know if it's uncomfortable for you. So we'll give some numbing medicine as we go in, because there are certain structures from the skin down to the spine and the disc specifically that are pain sensitive. One of them is the skin. The other is the fascia. The facet joint itself can be. Are you comfortable? All right. Thanks for letting me know, Sean. So we're going to use our x-ray machine to find the right place, lateral. And the first view on the x-ray is called an AP, or anterior posterior. It's front back, just fancy medical terminology, front back. And remember, the spine is a three-dimensional structure. To do this kind of surgery, we need a reference point to navigate to, from and to. And so the entry point is an area that I have a lot of experience doing thousands of these. Well, not thousands, but over 1,000. And now I'm pretty good at figuring out where I need to go in. Okay, so the end point is going to be the annular tear and herniation at L5-S1. And right now, I'm not happy with the x-ray view. So Jordan, I think we can improve that a little bit. Let's try I'm not really sure. It looks like some wag, at least some wag. Wagging means moving the x-ray machine in a plane that is up and down along the flank of the patient. I think that that is a little better, actually. The pedicles still have a double shadow. See if you can do a little more. Just a little more. Maybe we overshot it, I don't know, but try. Another degree, 1 degree. That's better. That's perfect. All right, now we need a little rotation, a little orbit. So we're going to now move the fluoro this way. So we're done wagging. The pedicles are lined up. The end plate's lined up. I think that's, I can't really tell if that's better or not. What do you think, Luis? Worse? Better? All right. All right. Well, no, let's just keep it there. All right, let's just keep it there. So you can see the L5-S1 disc, which is kind of, if you follow the trajectory of the needle forward, you'll see what I'm talking about. It's very collapsed. It's very collapsed. So we don't like collapsed discs because they're hard to get into. The L4-5, which we're also doing, the one above it is quite juicy and tall, and it just has a tear in it, which we're going to go repair. But this 5-1 is going to be a problem. Shot? My trajectory is pretty good. But just getting there won't be easy. Shot. I think I'm getting caught up on the facet. Let's go AP. Let's see where we are. Yeah, I think we need to do some more of the orbital stuff. I think our pedicles are not lined up. They're lined up top to bottom, but not side to side, not rotationally. All right. The facet. I need to get around that facet joint. Let's go back to a lateral. Any questions from our audience so far? I'm Dr. Ara Duke-Majan, CEO and founder of Duke Spine Institute, and the pioneer and originator of the Duke laser disc repair procedure, which we're doing. Somehow you lost your pedicle alignment, so let's get that back. And it's more of a wag issue. I think that's worse. Go the other way. Can't really tell. Try a little more. I don't think we're there. Try a little more. I don't know. What do you think, Luis? A little better? Yeah, I kind of agree with you. All right, let's leave that there. I think that's good. Good enough for government work. All right, shot. I'm starting to sneak around the facet. Are you comfortable? Shot. Huh? Shot. All right. Let's go AP. Any pain? She said nothing? All right. So getting into L5-S1 again is not going to be easy. But I can tell you right now, with the patient laying still, it's much better. That's perfect. Lateral. So if she was uncomfortable right now, I wouldn't be able to do this because she'd be moving around and she'd be clamping down. Like her muscles would tighten up in her back from the pain, and she would be squeezing the disc down. The chance of getting in would be 0. So I want to try to keep the patient as comfortable as possible for reasons obvious. And, well, again, it's better to be lucky than good, right? All right, we're into your totally collapsed disc, okay? And I'm going to prove something to the world, and that is that even collapsed discs cause pain. Are you excited about that? Huh? Good, good. Well, you should and shouldn't be. You should, because if your collapsed disc is causing pain, then we're going to fix it, and that pain will be gone forever. And then if your collapsed disc is causing pain, which I expect it is, you are going to feel that pain momentarily, which is the bad side. The downside. But it's an affirmative test we need to do. Are you comfortable, Sean? All right, let's get that. 4-5 looks perfect. I don't think you need to change anything, Jordan. It looks good. You're pulsing. So let's talk about pulsing and non-pulsing. Sean, what does pulsing mean? Well, what does pulsing mean? Anybody know? Does my audience know what pulsing means? What I'm talking about is the fluoroscope. Sean, I'm talking about the button on the fluoroscope that allows us to pulse the X-ray. See, what a fluoroscope is, it's an X-ray machine. It emits X-rays. It releases X-rays. And it releases them linearly. Well, somewhat linearly. Ideally, linearly. And there's an emitter, which is over here, and there's a detector. And the X-rays are emitted from one side of the patient. They pass through the patient's body, and they go to the other side, where there's a panel that detects them. Shot or a tube. We use flat panel fluoros because they're the best in the world. And what do I mean by that? Well, they have the best picture. Shot. All right, so I'm just kind of caught up on the facet. There we go. Should be better. Shot. I used to laugh at Dr. Patel and call him a needle jockey. But then again, I've become a needle jockey myself as a neurosurgeon. It's not something normally neurosurgeons are proud of, but it is essential to doing this surgery. So, how are we feeling? Are you about ready to go to sleep? Huh? What?
She said I am.
Oh, okay. Are you tired? All right. We're going to put you to sleep soon. That's the good news. I felt it go through the herniation, and then I felt it go through the annulus. So, all right. Now, she's a little oozy because she took a blood thinner, which we stopped, but these blood thinners that people take, they still do tend to have some effect on the platelets. It wasn't a medication. It was more of a what do you call it, herbal thing. Are you comfortable? Have you ever watched one of these surgeries before? Huh? What?
She said no.
What do you mean no? I thought we sent you an email so you could watch the surgery. You didn't bother watching it? You don't remember getting one? Okay. Interesting. Maybe that's a good thing. All right. Yeah, it could be. Are you comfortable? That just went in. Wow. Any discomfort there? All right, just pressure. Interesting. Well. You comfortable? How bad is it on a scale of 1 to 10? Well, how high did it go? Let's get some more. I didn't get enough in. Is that better? What's the highest the pain goes to? 10. All right. Well, is that where you typically get your pain? All right. So concordant, 10 out of 10 at 4-5, and I'd have to say pressure at 5-1. So the question is, do we do 5-1? And I think the answer is yes. because we're here, and I believe it's still causing leg symptoms. So discograms are really good to see if a disc is causing back pain, but they're not good to see if a disc is causing. Oh yeah, sorry. Yeah, you can go to sleep now. Can you count from 1 to 100 out loud for me? Yeah, keep going, and when you wake up, we'll be done with your surgery, and you get to go back to the recovery and go home. So what I was saying is, dilator. Oh, the discogram procedure, which I just did, injecting this small amount of dye into the disc, is called an evocative discogram because I didn't discover this procedure. It's been known for many years that if you put liquid into a disc that's painful, that causes back pain, that injection of that liquid under a slight amount of pressure, it actually will elicit the patient's typical pain that they get from that disc, herniation. So we use the discogram to look to see if a disc is causing a patient's back pain, which is, it's a good sign when it does. But it's a terrible test to see if a disc herniation is causing leg symptoms. Shot? Because that's just, you know, we don't do nobody does discograms to see if a herniated disc is causing leg symptoms. It's not the standard. And also in my personal experience for doing this for 15 years of discograms is that, Sean, is that it doesn't tell you any reliable information. The discogram doesn't give the surgeon or anybody any reliable information about whether the herniation is causing leg symptoms at all. You can't reproduce leg symptoms with the discogram. It just doesn't happen. People only complain of back pain when their disc is activated with the discogram, and or not. So based on that, at L5-S1, she didn't have anything but pressure. I don't think L5-S1 is causing her back pain. But I do think L5-S1 is causing her leg symptoms that she gets when she's walking, and then she gets pain down her right leg. So if I don't do L5-S1 right now, if I don't treat it, then I think she'll still have leg pain after surgery at L5-S1. So I don't want that. This surgery you're about to watch, Duke laser disc repair, is not just to treat back pain, it's to treat back and leg symptoms. So I have an obligation to do this level to fix her leg symptoms, even though it's not causing back pain, based on my discogram. Shot. Now the discogram is also not 100% sensitive test for back pain. I mean, there are discs that could cause back pain that don't activate with the discogram. In other words, is there still, okay, I was going to say, where's the wire? Right, it looked like it disappeared there, right? Didn't it? Shot. All right, so that's looking good. I'm starting to get into the disc space, but I do want to keep my wire in there just to make sure this thing doesn't go anywhere it's not supposed to go. Okay, so are we ready? Shot? Yeah. I feel it advancing properly. Shot. Now you can see, look at that. The bones have separated. The disc space is widening as the dilator dilates the disc space. So we are in, and I'm trapping my guide wire, which I don't want to do. If you just ignore the fact you're trapping your guide wire, then you can actually fracture your guide wire, which is bad, because then you've just put a piece of metal in the patient's body that you can't get out. You probably can't get out. I might be able to get it out, but I don't want to find out. That's bad. So at this point, we've got our dilator in right there. You all see that? It's beautiful, huh?
Yes.
Want one? And then we go over the dilator with our tubular retractor. So people ask me, some people think this is percutaneous, okay? Percutaneous in medicine means you put a needle in the body and you do everything through this little hole right here inside the needle. And for a long time there were doctors that would put a needle in like this, and then they would put a laser fiber Let me show you.
You want the laser?
Yep. They would actually take the laser fiber, or they would take a radio frequency probe. They look the same. One uses plasma, the other one uses light energy. And see what I'm doing here? Okay. They would take the laser and they would put it down the needle like this, voila, and they would push the pedal and hold it down for about 10 seconds, and then they were done. And that's called an intradiscal electrothermoplasty, IDET. It can be done with laser or it can be done with radio frequency. The problem is it doesn't work. So it stopped getting covered about 12 years ago. And that's a percutaneous procedure. Now what I'm doing is not percutaneous. This is definitely not being done through a needle. Percutaneous means it's done through a needle. So we are not doing percutaneous, we're doing surgery. However, the kind of surgery we're doing is endoscopic, minimally invasive, okay? And we have to make an incision to do it. So I'm going to bring this tube down over the dilator, and I'm going to bring the end of the tube into the disc, right through the herniation and annular tear. So as I pull the tube back and do my surgery, I can actually have the walls of that annular tear will fall down right into the front of my tube, and I can actually repair them and debride it. So the surgery really is a debridement of the annular tear. Shot. I want to make sure I'm not moving the dilator forward. Shot. Now I'm moving the dilator forward, which I don't want to do. So I need to get it out and pull it back a little. Shot. Let's see where we are. I think we're in far enough. I don't know. It's kind of hard to tell. I'll pull the dilator back a little more and see if we see the end of the tube. Whoop. There it is. Shot. All right. Well, we're definitely in far enough. We're good. We're in the right amount. So at this point, we get our fluoro out. Look how wide the disc space is now. We've opened it up. So by doing this, I can bring my tube backwards into the foramen slowly, and meanwhile I can remove the herniation that I just shoved into the disc space. I just have to find it. So we're treating the herniated disc, yes, which is what every other surgeon does. They take the herniation out, but I'm also treating the annular tear. And most of what I'm doing is treating the annular tear. She comfortable? Everything good? All right, we are ready to rock and roll. How come we don't have any music? Who's in charge of music? Here we go. We're going to get started, and we're going in to the disc. We're going down the tube. We're going into the disc. There it is. Bam. Inside the disc. Look at all the blue. That's the blue dye. There's nothing to grab right now. Take this. Okay, so that's bone, and where the I guess there's a little bit of disc. So let's have laser. So our patient is comfortably sleeping. She has no tube. This is all sedation, just like if you had a colonoscopy. Okay, except it's not a colonoscopy. It's better than a colonoscopy. Colonoscopies are diagnostic. This is a treatment, not a diagnostic thing. We're not diagnosing. We did do diagnostic early with that discogram, but we're mostly doing a treatment right now. We're repairing the annular tear. Ah, there's a piece of herniation right there. Let me have the grabber. Do we have music or not?
I think Gary's working on it.
Okay. Is Gary going to start singing? Oh yeah, there's a piece of herniation. Isn't that cool? That was actually sitting out in the foramen, pushing on the nerve, and I shoved it back into the disc, and then I'm taking that piece out. There's another piece, good size. Isn't that amazing? The herniation in this lady who's a bit older. You wouldn't think there's any herniations because the disc is so collapsed, but there is, you know. I think that's it. I don't know what that is. That's, let's see if that's attached. All right, take it. So I've been trying to get my kids to appreciate music from my generation, my era, my time, which was real music, by the way, sorry. You know, everything from the Bee Gees to Bon Jovi, John Bon Jovi, and, you know, Deep Purple and all that good stuff. Trying to explain what rock music really is. It's all drums and guitar, and it's a rock ballad, you know. It's a story about love, usually. Unfortunately, rock music isn't made anymore, right?
I think it's coming back.
Is it? It's good. It needs to make a comeback. Yeah, the songs these days that the kids listen to, there's really no substance at all. There's no story like there used to be when our generation. All of our songs had a story, you know? Bryan Adams, Summer of '69. Duran Duran, Depeche Mode. I mean, no matter what the music was, what genre of music it was, in our time, there was always a story. If you listened to the lyrics, you understood the story. Sometimes it was silly, like Cyndi Lauper, you know, girls just want to have fun. But it was really an amazing time, you know, to have female rockers coming out, making great music, breaking in. The problem is all the good artists, most all the good artists were British, which I don't have a problem with that, but apparently the music industry of the United States did, so they shut them all down. And they said, we want American artists. We want to keep all the money. So they basically turned off all the British artists off the airwaves and started turning on rap, which I call crap. So when I say crap, I'm really saying rap. Okay? There is some good music made in the United States, but I don't like the idea of the control. She's coming off the bed a little. All right, lay still. You're doing fine. Everything's going well. Just lay still. So we talked about this disc here being pretty collapsed, and if you look down there, I'll show you. On the right side here is the end plate of L5, which is the bottom of the L5 bone vertebrae. Here's the superior end plate of S1. And you can see just a little bit of this annulus still attached there. But there's not much herniation here, right? So we shoved a lot of the herniation back into the disc. Let me know when I can proceed. All right, so she was a little light, and this is the painful part of the disc, by the way. This is the outer part of the annulus, the outer half. When you get out here and you start zapping with the laser, it hurts. Because remember, the pain fibers are here. So people, any neurosurgeon that watches this will quickly learn and understand that the disc does have pain fibers. Because I'm zapping them right now and the patients always feel it. That's why we have to put them to sleep. If the disc itself was not painful, then the patient wouldn't try to get off the table. We are just about done with this disc. I just need a little more. So we're listening to Knocking on Heaven's Door by Guns N' Roses. And one of the things that's unique about this style of rock is the fact that they brought in orchestral music, right? Guns N' Roses was one of those first bands to start bringing in a full orchestra for some of their songs, where you have violins, cello, strings. I mean, really quite incredible to mix drums, guitar, vocals with an orchestral movements, and really created something special. All right, good. Laser off. Let's take a look and make sure. Unfortunately, the nerve root is buried in a little fat, but it was being pinched right here. So everything looks good. I'm happy with it. We got those herniations out of the disc space early. Okay. Great. Okay. All right, so one disc down. That should eliminate her pinched nerve symptoms, right leg symptoms. What kind of speaker are we using? It sounds terrible. What? Don't we have speakers in the ceiling? Why are we not using those? Why would I have spent the money on those and we don't use them? Huh? When you went to the bathroom in the men's locker room, did you find the toilet paper? Yeah. Is it in the same place as it is at your house? No. Your house, it may be on the right side. Here it's on the left side. Did you find it? Yes. You were motivated to find it, weren't you? So why can't you be motivated to find out how to use the speakers in my operating room? Push that down. See, I don't ask people unreasonable things. I just ask them to care. So a little hint, if you don't know how to use them, I would ask Sonny. You want his extension? All right. So we're done with L5-S1. We're about to start L4-5. L4-5 is going to be a different experience because just looking at that disc on MRI, looking at it on X-ray, I can see that it's a big juicy disc and that it won't be collapsed. It'll basically be a tear with a herniation, but it won't be totally collapsed like we just saw at L5-S1. So she had 10 out of 10 pain, which was concordant, meaning it's her typical pain, Sean, at L4-5, where we're about to fix. So I believe fixing this disc with the Duke laser disc repair will actually cure her back pain. I know that. I know that because I've done it over 1,000 times. 1,000 different patients. And it always works. Beautiful. That's what I like to hear. All right. So once again, shot, we'll bring our, so your pedicles are double shadowed. You see that? At 4. Can you wag it somehow and get that better? Herniation, by the way, at 4-5. I can't point it out to you, shot. But there's, all right, now look at that. That's pretty cool. Look at the tip of the dilator. It's in the foramen, and go to the left of the dilator tip. Literally, the white space that's there, and then it gets gray, and it looks like a shadow, a curved shadow. That is the herniation. Okay, pretty cool, huh? So now, shot, the tip of the dilator is actually pushing on the herniation. You see that? Beautiful. So how come we can see the herniation on an X-ray? Because we put dye inside the disc, and it kind of moved out towards the herniation and highlights the herniation, so to speak. It's really amazing technology, isn't it? It might be loud. Well, that would be horrible if rock and roll was loud. startle us, please. We need to be startled. Nice. Little scorpions. Just what I like. That's nice. Since we have no questions,
We might get taken off Facebook.
we
might get taken off Facebook.
We might get taken off of Facebook. Oh, geez. That would be Facebook's loss. Take. All right. Let's see what we got. Shot? We lowered it a little bit. We don't want to upset Mark Zuckerberg. Not that he cares what we do here. All right, we're in like Flynn. You can see the tube coming from the right going to the disc. It's passing through a hole that's already there, which I showed you guys during the last video when I showed you the little spine model. So we're actually not going through any bone. We're not taking any bone out of the spine like every other surgeon will do. We are going around the bones, leaving the bones there, because that's why God put them there, to stabilize your spine. So surgeons that take bones out by doing microdiscectomy, laminectomy, they're disrupting nature. They're disrupting the design, the natural design of your spine. Those bones are there to stabilize your spine, no matter what surgeons say. When they do open back surgery on you, they're taking those bones out. And that's bad. But that's the only way they know how to fix your spine. So they're going to continue to do that until they learn this technology that I have used and pioneered now for 15 years. You got to ask yourself, is that really what you want? Do you want to have surgery that's ruining your spine rather than repairing it? Okay, this is the tear. It looks pretty bad. See, the golden stuff is calcium. That's from the beginnings of bone spurs and what we call dystrophic calcification. So that's your body response to damaged tissue and chronic inflammation. All right, we're right inside the disc, right inside the tear. I need about 8 minutes and we'll be done, doctor. So what do you think about these surgeries so far? Are they enjoyable for you to provide anesthesia for them? Are they challenging?
It's always a challenge with neurosurgeons, fine, but it's a good challenge.
Yeah.
And the patient selection is patient based. Surgery so slick, I enjoy it.
Oh, good. Well, I enjoy it too.
That's why I enjoy neuroscience
Yeah.
together.
Good. That's what we're going to do. By the way, for those of you interested in knowing, the laser I'm using is called a straight fire laser. There's also a side firing laser, fiber, which I don't use. I don't use it for a lot of reasons. A, it's unnecessary to get the great results we get. I've never used it. I mean, I've used it, practiced with it, and tried it, but I've never used it like routinely in my surgeries because it's totally unnecessary. The other thing about it is it's much more expensive than this fiber. This fiber is relatively inexpensive compared to a side-firing laser fiber. But they're always trying to get you to buy the side-firing laser fibers because they make more money on them. I'm trying to keep the cost down for my patients, so I use the straight fiber, and it's fine. This is all I've used for 15 years, and I have the best results out of anybody that does endoscopic surgery with respect to curing back and leg pain. Even Dr. Anthony Young, I have better results than him. He was my greatest teacher, and he's still alive. He's not practicing. He teaches this technology in China. He's Chinese, and he had a complication rate of 10% of having nerve basically a nerve injury. He tells everybody that while he does his teaching. So it's nothing secret. He calls it dysesthesias. He blames it on what's called the furcal nerve. He's funny. I like him a lot. He's a very smart man. But I've never heard of or seen the furcal nerve ever before. He's the only one who believes in the furcal nerve. And I'm a neurosurgeon. He's an orthopedic. So neurosurgeons know a little better. But I've never had those problems with dysesthesias in the leg after the surgery with my technique. So the goal of his surgeries has always been leg pain, sciatica treatment. My goal of surgery is curing back pain and leg pain. He's never been able to cure the back pain. He does sometimes, but he doesn't do it routinely. And that's because, by the way, that's just the dye coming out of the disc. That's because he doesn't do an annular debridement. I discovered the annular debridement and pioneered it. But he doesn't really follow my surgeries like I followed his. I learned everything I could from Dr. Young, but he had a few things he could have learned from me, but he never did. Rarely do teachers learn from their students. Now, he did learn that I do cervical, which is the ones in the neck. He never did cervical. He only did lumbar his whole career. For 30 years, he did lumbar endoscopic surgery. So I pioneered cervical in the United States. And he recognized that I'm the first really to do cervical. So he would have me come and give lectures at his meetings. He would have me talk about the cervical spine. But in reality, my results with respect to curing back pain are far better than Dr. Young's. And my results of curing leg pain are a little better. Not far better, but a little better. I'm at 95%. He was at 85, 88%. Depends on which paper you read of his. And I'm not trying to brag here. What I'm trying to teach you all who are watching is that the development of this endoscopic technology over the years has been what we call like staggered and progressive. In other words, I built on a technology that Dr. Young learned, and Dr. Young learned it from Dr. Parvis Camben. So basically, he made Camben's technology better with his own YES technique. That's the Young endoscopic spine surgery technique, YES, Y-E-S-S. And then I took the YES technique and then made it better because I combined it with the Koreans and I combined it with the German surgeon who did endoscopic transforaminal surgery. And I created the Duke laser disc repair. So we've built on the success. I've built on the success of a prior generation of endoscopic surgeons to make my surgery even better. And that's the only point I'm trying to make, is that real pioneers in medicine build on the success. They stand on the shoulders of giants. I can't take credit for everything, but I did improve what I was taught and made it better. And I think that's important, is that no matter what you do in life, is that you try to make it better and do a better job than your predecessors who taught you. And sometimes there's jealousy issues, you know. When I first developed the Duke laser disc repair years ago, I went back to the University of Florida and I tried to share what I learned, how I help patients with back pain and neck pain and cure them. I tried to share it with my old attendings, and they, unfortunately, they didn't believe it. And I didn't have all the videos back then like I do now, but I stopped trying because they basically didn't believe, like every other neurosurgeon, they don't believe you can cure back pain, which is really a big problem, folks, because if you're surgeons you need a surgeon to do this procedure. And if the surgeons don't believe it can be done and don't know how to do it, then you're stuck with me. It's not a bad thing, but I'm not going to live forever. So fortunately, my kids are interested in medicine, and maybe someday they'll come along and they'll take what I did and make it better. But it's weird because this technology is literally here, and that's it. Right? Even though I've been telling people I'm happy to train surgeons to do it, they don't come flocking here to learn this technology. It's weird. They just want to keep doing what they're doing, making money, putting screws and rods into patients. So I can't get them. I'm not going to try very hard either, but it's up to them to figure out what this is and how beneficial it is to people. So anyway, our first patient is ready to go. So I'm going to finish here in the next 4 minutes, and we're going to go see the first patient before she leaves, see how she's doing. She was a single level, L5-S1 if you recall. You were here earlier, Duke laser disc repair. And she's the one that had mostly leg, correct? Mostly leg pain. So we'll go check on her. All right, things are going well, almost done. There's the end of the tear. And that's where the posterior ligament is. I came in pretty laterally for this one, so I could get more medial in the disc. Something I didn't discuss with you earlier, but the more medial you want to get, so if you have a more medially positioned herniation, you have to come in a little more lateral. But you got to be careful, because if you go too lateral, you'll puncture the intestine. You'll have a perforated bowel, and you don't want that. Or you can damage the kidney, the ureter. The ureter, the kidney, all those things are just right there. So I make this stuff look easy. I make it look like I just walk up and stick a needle in, but that's taken me many, many, many years to develop that exactly where I go in and exactly at what angle. So it's not something necessarily that you can just watch my videos and learn. You need to actually be trained properly, corrected, supervised. So if you're a surgeon out there thinking, oh, I'll just start doing these surgeries, I wouldn't do that, because you're going to hurt people. You need to really have supervised training. And I'm the only guy in the world that can do that for you. So pick up the phone, make the call. Who are you going to call, Luis? You're supposed to say Ghostbusters. Yeah, Duke Spine. That's correct. By the way, for any surgeons interested, we'll be hosting an educational forum in 2 weeks or 3 weeks, I think, or actually next month.
It's going to be March 5th.
Yeah, actually he said March 5th, so that's our final date. I apologize. March 5th. We're going to be hosting sacroiliac joint fusion training. So if you want to come, you want to meet us, you want to learn how to do an SI joint fusion, we're going to be working with a cadaver to do that. Actually, we could probably broadcast the entire lab. Right, Luis? Yeah, so we'll broadcast the SI joint fusion lab. We'll have a faculty member here who will be teaching and instructing, and we'll have a cadaver so we can broadcast it. So anybody who wants to watch, it'll be on a Friday or Saturday?
It's a Friday.
It's a Friday. I hope you guys can join us. Sean will announce it as we get closer to the date. But the sacroiliac joint is a joint that is just below the spine. It's where the tailbone connects to the hip bone. And quite often the SI joints, there's a right one and a left one, they're big joints. Quite often they get inflammation and pain from those joints. Normally we do a shot in the joint and physical therapy for 6 weeks. If that doesn't fix the problem and it comes back, then patients could need a sacroiliac joint fusion, in which case that's an outpatient procedure, minimally invasive, and we'll be having a lab here at Duke Spine Institute. If you want to come out and participate, just contact Duke Spine Institute and ask for Luis. And if you're interested, we'll get you out here and we'll train you. I Need 30 Seconds. Great song by Metallica. Any questions, Sean?
We do have one viewer from Facebook wondering, you said you like techno. What artists do you like?
What artists in techno? Yeah, great question. Well, I like Avicii, for example. But you're talking about Goa techno, my old techno? I don't remember the names of all the artists, to be honest with you. There's an old techno track called Distance to Goa. Distance to Goa. It's from the 90s. And that's got amazing music on it. Distance to Goa, G-O-A. So, I don't really pay attention to the artists, but those guys are all really good. That whole soundtrack is amazing. All right, we are pretty much done. Laser off. Let's see what we got here. And again, we can't see the we can't see the nerve root because it's just buried there in the foramen. Let's see this right here. I want to get that. Laser on. So I'm going to get those little chunks right there. They're kind of not in a good spot. We're just about done. I'm just getting these last little pieces of disc herniation. Let's have the grabber. Laser off. Our patient is just about awake. Looks good. We're done. All right, hope you enjoyed the surgery. We got one more for you after this, but before that last surgery, we're going to go send off our first case, okay? Good job, everyone. Any questions? If you have a question, type it up. Anything to do with the spine or insurance companies or healthcare in the United States, don't ask me what I think about Joe Biden's plan because I have no idea what he's going to do. I mean, I've heard things, but we don't know until he does things, right? So I know Joe Biden was just inaugurated yesterday, right? So I honestly have no idea what he's going to end up doing, but I can tell you what needs to be done. He needs to regulate the health insurance companies and keep them from profiting so much while regular people are getting denied the medical care they need. That has to be fixed. I hope he can do that. That's one thing the Obamacare failed to do. Sure, it gave insurance to everybody, but the co-pays and deductibles were so high that the people on Obamacare couldn't afford treatment. Insurance companies are sly. All right, I'll be right there and we'll answer questions. So type your questions up, please. You can turn that on the music. Okay, Dr. Dugmajian, and it is January 21st, 2021. I just finished an L4-5, L5-S1 Duke laser disc repair, endoscopic disc repair with annular debridement and discectomy. The patient we just finished is on her way to recovery. We'll check on her later. Meanwhile, we're going to go see the first patient we just did about 2 hours ago. She was a right-sided L5-S1 Duke laser disc repair. So let's go check on her in recovery. We'll